And during those kind of final few minutes of the resuscitation, at every 2 minutes, every pause, he would ask the question to the team congregated around that cot, can anyone think of anything else we need to do? Am I missing anything? And there may be the suggestion that we need to call the parents in to the hospital, or maybe it was another shot of adrenaline that was needed. But nevertheless, there was that moment that everyone had the opportunity to contribute to those final outcomes.
You're listening to the Medical Protection Podcast Real World Series, where we expose the pain points and explore how we navigate the complexity of healthcare today. My name is Dr. Najib Rahman. I'm an emergency medicine consultant in the NHS, as well as a senior medical educator with MPS. In today's episode, we're going to try and better understand the meaning of quality improvement and how it applies to all of us. While many of us may have experienced the range of superficial, short-term and unsustained projects branded as QI, often in response to incidents or training requirements, it's important to recognise the real value that genuine inquiry and engagement can bring in supporting meaningful improvement, and where the gains to be made are for us, our teams, and our patients. Joining me today to explore these concepts further is Dr. Hisham Abdullah. Dr. Abdullah is a consultant paediatrician and head of integrated quality improvement at Oxford University Hospitals NHS Trust. So Hisham, I wonder if you'd be able to start off by describing your journey into quality improvement work for us. I mean, many of us who are aligned more heavily towards clinical practice may not fully really appreciate the value of QI. And in fact, many even might have a degree of antibodies towards such initiatives because of the way it interferes and has negative experiences in our daily practice. So it'd be great to hear a bit about your story and how you got into this kind of work.
Sure, Najib. I think I probably started being interested in improvement pretty much as soon as I graduated from medical school, actually. I came out of Manchester University Medical School very inspired, ready to kind of hit the ground running. And then I have to say I was quite shocked at the difference, the contrast between the care that I'd been trained to deliver, that we aspire to deliver, and the care that my patients were receiving. I was seeing patients dropping really in the chasms of the patient pathway that I was meant to be the steward of. And I was involved in a couple of clinical incidents early on as a pediatric SHO, where I guess I was what would be termed now as a second victim in those cases. And I think it really angered me, both what was happening to them and what had happened to me. So I put a lot of work and effort into trying to do what we would probably call QI projects. But back then, it was oftentimes an audit and then like an improvement initiative and then trying to do a re-audit if it ever was done. And I have to say, to be frank, it didn't really make much difference, if anything. And any changes that I were to make probably weren't sustained beyond my energy or lifetime in that department, that I was rotating to. And I think I probably also, to be honest, developed some antibodies and perhaps maybe even gave up on that by the time I got to my kind of penultimate year as a trainee. And then something happened which I hadn't anticipated, which was I had the opportunity to take a year out of training to do a leadership fellowship at what was the Strategic Health Authority up in the Northwest back then. And I hadn't, I don't think I went deliberately to look for it, but it ended up in my kind of in tray, and I thought, okay, I guess I'm not in a rush to become a consultant. Maybe I could apply for it, and I probably did still have somewhere in my heart an interest in trying to make things better. And so I applied, and I was fortunate and surprised to get that place on that year out of training. And it was a transformative year for me, Najib. So myself and the other fellows on that program were taught about the technical aspect of quality improvement. We talked about leadership. I learned a lot about how to lead and how to be led. And actually, it really changed my mindset in terms of what the possibility of quality improvement was when done well. Although I have to say it was slightly bittersweet as well, because on one hand it was great to learn this stuff and learn that there is a science as well as an art to doing good improvement. But on the other hand, it was also kind of a little bit resentful that we're only being told this stuff now. I was thinking, how come it wasn't part of the core curriculum as a trainee or even as a medical student. And so I think probably as alumni from that group, a lot of us probably felt similarly. And many of us, myself included, went into kind of asked the question really, as well as learning this stuff, maybe we could teach it as well. So I went on to do a master's in clinical education and then further degrees in quality and safety. And I've had essentially kind of twin or kind of parallel careers really ever since, as a clinician and a clinical lead, as well as an educator in quality improvement and leadership. And then finally, those two kind of roles or those worlds have combined or collided really in this current role in OUH, where I'm now heading a QI team whose core purpose is actually to cultivate an environment where QI can flourish, training, supporting, mentoring, coaching, and convening staff, my peers, juniors, to work on improvement programs and to align their projects with those organizational priorities that can make the most difference. So that's, I guess, a potted history of really what's got to me to where I am now.
Oh, thank you, Vishal. I mean, that was really rich and a lot to reflect on, actually. And it seems to be there's something to be said about not parking your second interests away, because I guess traditional medical education and training is very much funneled to an endpoint where you get CCT, for example, and perhaps we don't get the chance to really delve deeper into those other interests. And it sounds like the leadership fellow really, as you said, was transformative in allowing you to expand some of those other skills. And so perhaps there's a lesson to be learned about, giving yourself time to invest in your journey and development along the way, even though that might be outside the scope of a traditional training curriculum, perhaps. I don't know if you agree with that or not, but there's lots of lessons there, I think, in terms of how we progress our careers and how we feel fulfilled and manage resilience and burnout as well in some ways.
Sure. I mean, I have to say, I get so much pleasure from learning and teaching. I'm on my third master's course now. I'm passionate about learning and imparting some of that knowledge to others. And in many ways, that is my kind of oasis during what can otherwise be a very kind of busy shift or clinical week. Being able to actually cultivate or really kind of delve into developing myself and others can often be an oasis within that week, particularly when it aligns with my true purpose, which is around improving care for the patients and service users that we were responsible for. And I think that does help certainly my sense of well-being. I think it has helped me avoid burning out. I talked to a lot of my consultant pediatric colleagues actually, and many of them actually would, I think, benefit from maybe taking a bit of time off the clinical coalface, perhaps maybe not dissimilar to how you're doing as well, Najib, and thinking about what are the supplementary things that they could do, bearing in mind their wealth of knowledge and experience and wisdom that could actually be making a difference at a systems level. And I think that's really where I feel I can most contribute with that kind of extra supplementary interest.
So let's bring it back to the system then, because that's, I guess, partly what we're having this conversation about. How do we beat the system with QI, as we said?
Yeah.
So clearly there's more to it, right? When we're thinking about what gets in the way of getting the job done safely, getting it done well. And yet we all come into work to do a good job. None of us come in to have negative outcomes for our patients or ourselves. So what can we learn when we take a step back and we really try to understand what causes harm in the first place?
Yeah. So I think this is probably best illustrated with a story in terms of what the causes of the problems or the systematic errors, but also what we can do to address it. So my current master's degree is in human factors and patient safety, and I guess a quick one-sentence summary of that is: how do we make it easier to deliver good care and harder to deliver bad care, is as a design principle that we want to instill within our kind of QI, quality improvement redesign. So as I said, by way of an example, in my previous trust, I was director of postgraduate medical education, and every year as educationalists, we conduct a survey conducted by the GMC of our kind of trainee feedback. So there's a kind of that many of the listeners probably will have completed or will have seen. And in my previous trust, we had a number of kind of red flags come through last year from the core surgical trainees. So there was some significant concerns, partly I think exacerbated by COVID, but also the ones that really alarmed me was around kind of bullying and undermining. These are all anonymous, so I thought it would probably be useful to get a little bit more detail behind that. So I spoke to a couple of the core surgical trainees, and what they confirmed is, yeah, Dr. Abdallah, it's really bad. The culture's really horrible, but it's not the consultant surgeons that are the problem. It's those, and forgive me for saying this, Najib, those A&E team who are bullying and undermining us. And what they will often be doing to us is referring patients inappropriately, surgical abdomens that aren't really surgical, and shifting patients and shifting blame and shifting those patients. So this kind of essentially, and if we refuse these referrals, then they'd get their senior consultant colleagues to kind of undermine us and shift these patients down the corridor to us. So I said, okay, well, let me go and speak to those ED teams, because I know them. They're not bad people, and it'd be good to understand what their context is. So I went to speak to the ED team and spoke to the clinical lead, and she concurred. She said, Hisham, it's really bad, but it's not us bullying the surgeons. It's the surgeons who are bullying us, actually. And what they are doing is refusing to take these patients, who are clearly got surgical problems, and we got the pressure that they don't necessarily see of all these patients backing up in our department, and that is causing real animosity. And she described it really quite visually as running battles in the corridor. So this kind of turf war that was going on. And actually, the key bit here is actually this is the disadvantage this is, or the problem this is causing for the patients themselves, who are falling in those cracks I described earlier on. So here we are with this kind of dilemma. We've got two teams, both good people, both coming to do the best job they can, but a culture and an environment which isn't fit for them or for the patients that they are responsible for. So where does QI fit in with this? So with a QI mindset, what we're looking for is what are the systematic features that are leading to these poor behaviors, poor practices, and poor outcomes. So typically with a QI project, what you'll do is you identify your stakeholders, you bring them together, and oftentimes thinking about a shared aim, and then developing kind of a pathway mapping process. And that's where we went, and I was able to convene these individuals as a kind of honest broker, I suppose, as because I'm a pediatrician, I don't necessarily fit within one tribe or the other, so it probably put me in a good position to be able to do that. And what I could see was actually, in many ways, this was system was perfectly designed to deliver the outcomes it delivers. That's the kind of one of the kind of big totemic improvement statements. So it's a lot easier to get a CT abdomen in A&E, for example. You can get it within an hour, but as soon as that patient has been moved over to the surgical team, down the corridor to the surgical assessment unit, it could be 4, 6, 8, 10, 12 hours if that CT abdomen hasn't been done to get it done at that point. Which, if it turns out that this isn't a surgical cause, then the surgeons are often left with this patient trying to refer on to the medics, who themselves are then reluctant to extend their safari ward round even further to the SAU. And so that in itself causes more problems and more kind of backlogs, so to speak. So the intervention that we put in place, which is relatively simple, kind of thinking back on it, was actually what we arranged is a service level agreement, an SLA, such that those CT abdomens could get done a lot quicker in SAU than they would have done otherwise. Not quite as fast as they would have got done in A&E, but nevertheless quickly enough to be able to make a fast decision, and if necessary, that patient moved on and referred appropriately. And by doing that, what we've achieved is fixing the pathway and thereby preventing some of those unwanted behaviors. And actually, what was really nice to hear from those trainees who I kind of stayed in contact over the following few months is what difference that made. We did a whole bunch of other stuff as well, but that was clearly one of the big interventions. That was really about using that kind of dispassionate approach to understanding the system, looking at what the contributors are to those changes, and then deciding on sometimes very small but significant leverage points that you could then press on to have that disproportionate impact across the system that we're trying to solve.
That's fascinating, Sham. And I think, and correct me if I'm wrong here, but essentially it was able to break down where the value proposition was and what was, I mean, as you said, people were very entrenched in their own view, one which was a blanket kind of approach to say, we need to get these CTs done. Otherwise, we're going to be, struggling with our patient caseload and flow. And likewise, the other team saying, actually, the CT is not my problem. We just need to get these patients through.
Mm-hmm.
But actually, where it was missing in that is, well, where are the value add components in that patient journey? And by able to stripping that down, able to kind of pace it in a more reasonable way with a service level agreement, that only improved patient care, but it also looks like it really improved the kind of psychological safety and the kind of affect and the mood of some of the teams as well, and perhaps allowed them to have a bit more dialogue for maybe future issues that might arise, I guess.
Yeah, and that last point is really important as well. So although it was a technical fix, actually what was perhaps more valuable, and certainly for me, one of the more gratifying things is those kind of relational changes that happened. When you sit down and break bread with someone and recognize actually, they've got problems that we might be able to fix and vice versa. The surgeons were able to share that actually they're not spending all their time sipping coffee, but actually many of those surgical trainees have had their training decimated by COVID. And actually, those precious moments that they have in theatre, which are being interrupted by ED referrals, actually was really quite kind of problematic for them. And sharing some of those experiences, as the ED would be sharing about, the pressures that they were under, actually meant there was a much stronger foundation for other problems to be solved. And we set up a kind of little shadowing opportunity for them, kind of reciprocal shadowing, which also kind of built on some of those relational issues. So yeah, totally both those points, Najib, that kind of value stream mapping, understanding where the value added are within the system, and what can we do to maximize those and reduce waste. I guess that's the key thing. But secondly, QI is they say 80% relational, 20% technical. So building on that relational and deliberately thinking about those relational aspects was part of the ongoing solution.
So this is definitely kind of try to make sure you've got your proverbial QI hat on. It allows you to think slightly differently, doesn't it? And I remember when we were speaking at another point, you mentioned this term, which I really caught it onto, and I hope I can steal from you, is a right cause analysis. I was wondering if you could share a bit about that story, for our audience, because I think that was a really powerful story about understanding how to look into something that would normally be done very negatively.
Yeah. So this is something I only kind of learned to do recently, actually. So this was after, again, through my kind of own studies and looking at what we call safety too. So looking at where things go well as a way of understanding systems, and then asking the question, why did it go so well? What can we do to make it go this well every time? Which is very different to our normal clinical governance systems, which are very much focused on the other end of that kind of, parabola, at the clinical incidence and the never event. So actually focusing on that, the extremely good stuff is actually a really good source of insight, but also energy. When we've conducted these, as I said, rather than root cause analysis, right cause analysis in the past, it oftentimes draws people in rather than the opposite. And one of the first ones we ran was when in my previous trust we set up a kind of a learning from excellence reporting system, and we had two reports come through. So I think some trusts call these there's different terminologies that we use, but that was our one. But there was two reports that came through, and then a third one concurrently, all about the same incident. And I thought, wow, there's something very interesting here. We've got three incidents, all positive incidents, excellence reports, all around the same occurrence. And that what was even more shocking was that they all related to the death of a child, of an infant. So we're saying, how come staff were nominating each other, unbeknown to one another, actually, as it turned out, all about the same incident? So that really raised my curiosity, which is why we thought we'd run that kind of right cause analysis. And so I conducted interviews with several individuals involved in that incident, and what the story transpires was that this was a neonate on the neonatal unit who had an inborn error in metabolism, who had died tragically on that night. It probably always was going to die. That I think it was a condition she was never going to survive from. But actually, what was really interesting as you read the reports is that clearly several of the members of staff who reported one another were chimed on this idea or this understanding that everything that could have been done for this child was done for this child. So that was a real sense of that. And when I asked the question as to why that happened, what they described is a resuscitation that was led, and it happened by one of our senior trainees, which is probably significant. We might mention this later. And during those kind of final few minutes of the resuscitation, at every 2 minutes, every pause, he would ask the question to the team congregated around that cot, can anyone think of anything else we need to do? Am I missing anything? And there may be the suggestion that we need to call the parents in to the hospital, or maybe it was another shot of adrenaline that was needed. But nevertheless, there was that moment that everyone had the opportunity to contribute to those final outcomes. And so for me, there was something really important in terms of the learning that came from that, in terms of how do you include the members of the resuscitation team in decision making in that way that really flattens the hierarchy and enables the best outcome that could be made for that patient arrive. And it meant that in the end, the parents were at the bedside when they would not necessarily have been. It meant that we'd exhausted all the potential opportunities to all the potential treatment options, and those staff members were able to say that message that I just conveyed to you to the parents was comfort, and the baby died with dignity.
Wow. Okay. So there's a lot to unpack there from both those stories. One from, about the surgical trainees, and obviously, the team working and dynamics around a resuscitation attempt and the inclusiveness of decision making. But from both of these, and you've known me for quite a while. You know that I dabble in humanitarian response work, and one of the critical functions in humanitarian response is around coordination, collaboration. And in both these situations, there seemed to be this really powerful role of facilitation that you yourself played or other members did. So, is that integral to QI? I mean, what happens if you don't have that facilitation role? How critical is that to improving outcomes, and what would happen if that role wasn't fulfilled? It'll be good to get your views on that.
Yeah, no, it's really interesting, and I think that in many ways, it seems a bit strange for me to say this. The problem is because although QI is good quality improvement is integral to it, to involve the people who deliver the care to improve the care. The understanding, a correct understanding, is that those individuals who know the service the most intimately are the ones who are most likely to be identifying both the flaws and have experienced the frustrations perhaps with where it doesn't work, but also can sometimes come up with the best solutions because they may have tried things, they may have adapted it, or kind of may have developed hacks themselves and how they've done things. So it's really integral to good quality improvement, and that's where you go for ideas, innovations, and potential solutions to fixing those kind of systematic problems. The problem with those individuals doing that thing is that because they are so intimately entwined in that service provision, it's much more difficult for them to take a helicopter view and understand both what are the things that are contributing towards those problems, but also how, and this is really important and most often neglected actually, how their fixes might actually cause unintended problems elsewhere. So that their hack, I don't know, an IT fix that they've put in place might be great for them, but actually that might make it really terrible for the digital team who now has yet another system that they have to try to kind of invigilate. So having someone who is able to take that helicopter view and getting people to think differently about what those unintended consequences are, thinking about them in advance, anticipating those particular problems is really crucial. So, and I'll give you a third story just to exemplify that. So one of my most recent coachees, she is a chief registrar at my trust, and she was working on a leadership program recently, and her improvement initiative was really around trying to expedite discharge from the ambulatory assessment unit that she was working on. So her kind of big idea and that of her team were all around how do we discharge patients from the AAU to the discharge lounge. So how and their kind of initial starting point was, let's see if we can get as many of these patients out to the discharge lounge or the transfer lounge, by midday. So that was the initial aim. But what I did through coaching her is, again, I had to think a little bit, her and the team rather, about what actually the consequence of doing that. Because all you've really done, although you've reduced the headache, and potentially you've allowed more patients to come up from A&E, which was good, and potentially could improve flow. All that's really done is also push the same problem up the corridor to another department within the same organization, who are then having to deal with those patients, and actually adds work in, because you're going to have to process those patients a second time. There's risk of errors, mistakes, whether it's in the medication or just transferring it. So actually, by adding an extra step, it may well have alleviated your problem, and it might actually make things a little bit better for flow to your part of the organization. But actually, from a value point of view, coming back to the point you were describing, Najib, you've not added value into the process that you're looking for. And so actually, what I did was coach her and the team into actually a very different QI project in the end, which was all about improving the estimation around discharging. How do we get a more effective discharge EDD, estimated date of discharge, around AAU, and thereby help with kind of planning for that process. So it's just a nice example of a very valid and potentially quite significant QI project, which would have made it better for that team, but actually, from a system point of view, actually probably wouldn't make it better. In many ways, would have made it worse for the organization as a whole, draining more resources.
Hisham, I mean, thanks. So this is really interesting because, we talked about the first case around the surgical trainee feedback and the interactions for there. We've kind of explored that pediatric resuscitation scenario and this last scenario around discharges. I mean, what strikes me is that, despite what we want to describe, this is all about leadership and engagement and stakeholder engagement and participation. So you're not really trying to dampen down those responses that are held organically in different teams. We're just allowing them to think and have the headspace to think a little bit more broadly within the system. And perhaps that's what's often missing, isn't it? Between a lot of the work that we do is that we look at it in a very short term, whatever we can see at the end of our own visual field, for want of a better phrase. We find it hard to look beyond that horizon. But if everyone's doing the same thing, it becomes very difficult then to really make the changes required. And what strikes me a little bit from all of this is then there clearly is an interconnectedness between some of these themes that often are talked about quite in siloed fashion. When we talk about leadership, we think of it, that's the leadership person. You've got a QI department, you've got a governance department, you've got someone looking after well-being, resilience, and training and safety. But really what comes across from those three stories is these are all kind of interconnected, are they not? Issues around speaking up for safety and team working, issues around quality improvement and value propositions for patient care. Is that? But then if that's not how it's often framed, what are the risks if we don't get that model, that mental model correct? That we're all part of the machinery in some ways, and we all have cogs that are linked together. I mean, do you find in your experience that often people don't see this working together?
For sure, and I think your point there about kind of the connectedness between leadership and QI is essential to that. So in a way, when you're thinking about leadership or leading, the key question is, where are you going to lead people to, and secondly, how are you going to get them there? And the answer to that second question is using QI. Actually, the principles around QI, around start with the customer, around a systematic use of tools and techniques to try to ensure that the maximum benefit is extracted from the system you're looking at, from looking at an insightful use of data, particularly time series data. All of those are cut and dried or kind of QI tools, which are essential. But those QI tools themselves are useless unless there is a clarity around where you're leading people to. So that's the interconnectedness, certainly in my mind, between the two. As I said that a few minutes ago when I talked about kind of the relational aspect of QI, that itself is a really important in your leadership approach to bringing in change. is the best organizations in the country that that do QI have really built into their infrastructure a um, a way of building peer-to-peer connections that allow discussions around quality of care, but also improving the quality of care to happen. So I'd commend the listeners to look at a report that was just published last week, actually, by Warwick Business School, which collated the or summarized a 5-year program, a QI program that was run in 5 trusts across the country in collaboration with the Virginia Mason Institute. And what that program really vividly articulated from those 5 trusts who did the best had the best outcomes was that there was consistency of leadership, there was inclusiveness of leadership in terms of integrating, bringing staff into those improvement ideas, as well as the systematic approaches to QI that we would be espousing. So both of those need to be in place, both essential and neither of those sufficient.
So no, that's given me a lot to think about in terms of our role as senior. I know everyone is a leader these days in some ways, but it's true, we all have roles to play, whether we're trainees or non-healthcare or senior physicians. But as we kind of started this conversation, if you recall, I mentioned the word antibodies to QI, and I guess as we said, a lot of people's experiences tend to be improvement initiatives are triggered by some kind of incident. And so what do you think needs to change in terms of how we prevent patient harm? How do we really change the system when perhaps we're not all on the same journey that you've described in some of those really positive cases? Is there anything else out there that we can use, or stuff that's happening within the system to make QI better in how we respond to these incidents?
Yeah, it's a really good question, and I'm delighted that you've kind of raised this one, because I think where my certainly understanding and growth has through quality improvement is with an understanding and a increased awareness that actually at the heart of all good quality improvement is self-improvement. Actually, it's through the process of trying to bring about change that we learn most about those systems where they're dysfunctional and where they can be improved, but also crucially about ourselves as individuals, because that also we are part of the system. There was a great billboard I once saw, which was a set of traffic lights, and the point that was made is that next time you complain about traffic, remember you are traffic. And it's the same here. Next time you complain about the system, just remember you are part of that same system. So understanding how we are contributory factors to the malaise that is sometimes the health care is crucial if we're going to be able to do that, to make it to improve things. So really that using that mirror to view ourselves within the context in which we're working, I think is part of how do we address that paradox that you're describing, and change starts with ourselves. I think is perhaps the kind of concise way of looking at. And the final thing I'll say is I think increasingly with the levels of burnout and I think last month they had more people resigning from the NHS than any preceding month since the start of its history. So we're in a crisis situation from workforce perspective. And I think coming back to the point I made earlier, that actually using a QI lens to see where are the system failures and deliberately looking at how do we fix those pathway issues or resource issues, access to individuals and teams, such that it makes it easier to deliver good care in the way that I describe. It's going to be essential if we are going to have a sustainable workforce and an unashamed focus on improving provision of care from the perspective of those delivering care. I think certainly for me is essential in some of our own quality improvement focus going forward.
Okay, no, that makes sense. Absolutely. Just one thing I wanted to touch upon, and I recognize that our audience, will be from all different parts of the world, but something that I came across recently within the NHS, and most hospitals will now be adopting this, is something called the patient safety incident response framework.
Mhm.
I wonder if you have any familiarity with that, and if you could maybe just, I don't know, if you can share some views on that for the purpose of the audience. And I think it's a great, my understanding, it's a great tool for us to kind of start looking into and understanding how this helps us to do better QI work within organizations.
Yeah. So I'm really excited about this development, Najib. Still, it's an evolving area, and then I think there's lots of learning that will happen over the next few kind of months and years in terms of how to do that. We have now a few pilot sites that have been running this for several months, which are sharing their learning in terms of how they've used a systems lens to approach patient safety incidents. Is essentially what we're doing, and I think for me, the potential this comes with is taking away some of the often futile and wasted energy that are spent investigating individual incidents, which often, and your experience, I'm sure, is probably not dissimilar to mine, leads to a whole bunch of recommendations, most of which we already knew probably needed to happen. And many of those are impractical and probably aren't going to solve the problem in the short term. So this kind of really kind of micro lens approach on oftentimes really kind of traumatic and serious incidents is the way that we've been running patient safety and clinical governance in the past. What PSERF brings is the really strong steer to actually think about what are the causes of the causes, what are the systematic challenges that have led to, taking an example, rather than the pressure ulcer in Ward 9, the number of pressure ulcers that we're having across the organisation, and what can we do to prevent level 1 ulcers developing into level 2, level 3, and level 4, and therefore understanding what those changes need to happen, and deliberately designing designing systems to try to prevent that. And one small example, just using that pressure ulcer example incident as a focus, that one of my team, or the team person leading on healthcare association pressure ulcers is working on within my trust, is one thing that their team have identified is oftentimes it's the lighting within a particular cubicle or within a bay, which actually makes it much more difficult to identify early onset pressure ulcers. And so how can we improve the lighting, maybe reducing the density of the curtains, for example, or other systematic features around lighting within those wards, which means that we can thereby prevent some of those ulcers coming on and progressing later on, is a nice example of using that kind of PSERF framework. Still lots to do, lots to develop, and crucially to be able to really fulfill that potential. Leaders within organizations are going to have to take the significant and brave step, really, to step down from doing some of those in-depth clinical analyses, which would otherwise be taking up much of the time of those clinical governance teams. But I think it's doable, and I think there's a real potential there, and potentially it could make a huge difference.
Hisham, fantastic. It's been so nice and refreshing listening to this take on QI, which helps to really give that common thread to see how the only way we're going to make our system work better for us is through these QI approaches. And that QI isn't really a static silo. This is really quite permeable, but takes on these wider principles of leadership, of genuine inquisitiveness and engagement, and that human factors approach of acknowledging not just the system, but also the process and the people involved, and not being, emotive about it, and trying to actually be genuine in trying to understand where is the value for patients. Because ultimately, again, that comes back to the point where we go to work every day is to do the best we can for our patients. So thank you for that journey. I really enjoy that, and those narratives were very powerful to kind of thread those things together. I understand you're involved with an initiative called Hexitime, and I wonder if you're able to spend just a couple of minutes talking around that.
Yeah, sure, for sure. So Hexitime is a community of improvers, so individuals from across health and care who are interested in biggest terms, I suppose, making things better for their patients and for their colleagues. And I would encourage staff or who may be interested in this to join the platform. And what it provides for them is an opportunity to both ask as well as receive help from those individuals. It works on a a time banking basis. So essentially it means that it uses time as your currency. And so you can support someone else on a particularly kind of QI conundrum, or support them with any aspect to improve your services for a credit, and then there's a reciprocal basis as well. So if you're looking for help, you can use that same credit to kind of buy in extra help and support. And what's amazing about this community is it's grown from just a few individuals to thousands of individuals who are now on there with hundreds of hours of exchange. But by taking money off the platform, because we're using this kind of funny money time banking system, it actually diminishes bureaucracy and actually allows individuals to help and be helped in a way that they wouldn't otherwise have been done within your individual organization. So I'd really commend staff to have a look at that, onto hexitime.com, join up and join that kind of large and growing international community of improvers with that shared purpose of making care better for health and staff.
Well, thanks for that, Hisham. And I think, again, that aspect helps us to recognize, when you gave that traffic light analogy of being part of the system, I think sometimes it needs us to kind of acknowledge some of the wider aspects of the system and engage with learning and improvement in other parts of the system to see what might be transferable to ours. So it sounds like Hexitime is a really interesting proposition to help us to refine some of those skills and contributions as well. Yeah. I always like to kind of just have a quick chat about, beyond the career, what about the person? So you're a pediatrician. I know you're a father as well. I wonder if there's any life skills that you'd like to share with us before we sign off for today.
I was just reflecting recently, actually. This might resonate with some of the listeners, Najib. I remember when my daughter was just a couple of weeks old, and I called a friend of mine, Tarek, who was my peer at school, but he'd got married and had kids a little bit earlier than I had. Was that I was saying, Tarek, we're really struggling at the moment. My wife trying to breastfeed, she's got mastitis, she's in a lot of pain, she's not sleeping, I'm not sleeping. It's really tough. And he said to me, Hisham, listen, it's always tough at the start, but just remember it gets harder. So enjoy it whilst you can. And that same little girl is now 20 years old, and she's at her first year at university, and it's such a stressful experience taking her through that. I think he was quite prophetic in what we were describing, but I think there's something there in terms of the life lessons that probably can be extracted from that, in terms of taking every step and enjoying those moments of pleasure and pain equally. I think is something I'd probably still trying to apply.
Very much so. Hisham, thank you so much for joining us today.
Not at all, my pleasure. Thank you.
I'm not sure about you, but listening to Hisham has really got me thinking about my own experiences of quality improvement and what some of the barriers may have been in achieving more sustained and successful outcomes. Being able to take a step back and take in that wider view seems to be critical in understanding what is actually occurring and where observed differences are amenable to change, as well as what interventions may be impactful. I think Hisham reminded us of the importance of knowing who to engage with, which voices to listen out for, and how to keep stakeholders involved, and that all of these are important strategic elements in strengthening our approach to QI. I was really taken by the notion of how QI can not only help sustain our own professional roles and well-being, but additionally that of the wider team, and ultimately reduce the risk of patient harm. This all reminds me of a quote by the leading thinker in quality management, Dr. W. Edwards Deming, who said, "A bad system will beat a good person every time." Surely then, there's opportunities for us as practitioners, striving to deliver good healthcare, to lead and manage quality improvement initiatives with skill and insight to help beat the system. If you're a member of Medical Protection and interested in learning more about today's topic, or would like a certificate for listening today, please look in the podcast description for links for further learning. This is our last episode of the Real World series, so stay tuned for upcoming headliner podcasts hosted by Dr. Lynn McKinley. It has been a pleasure hosting the series for you. Take care.